Hi everyone, thank you for joining us today. So before we start, here are some house rules. This webinar will be recorded for RAM use. Please keep your mic mute throughout the session. We will also be live tweeting, so feel free to ask questions on Twitter and tag us at RAM Malaysia and using the hashtag no money, no honey. So if you have any comments or questions, you can leave them in the chat box or use the Q&A box, yes. So we will address your questions at the end of the panel discussions. The webinar is to encourage conversations and diverse opinions. Please respect each other and their opinions. Right. I'm gonna leave the hashtag and also the handle in the chat. So I'll just keep it here. So thank you for coming to our discussion today, No Money, No Honey, in which we will talk about the economics of sexual and reproductive health and rights. So what is reproductive justice and how is this related to closing the poverty gap for women? It is widely acknowledged that health rights, regardless of class, income, or social status, should be affordable and accessible to all. However, we are still far from reaching universal coverage. The proportions of richer and better educated women using modern contraceptives and have access the women and persons from different economic and social classes are disproportionately impacted by restrictive abortion and SRH policies. Theories and evidence show that reproductive rights for women and women's economic empowerment are very much connected. Reproductive rights should strengthen women's economic power by allowing women to achieve their wishes regarding the number and spacing of their children. Contraception can reduce abortions, reduce the risk of maternal and child mortality, and to promote economic growth and women's empowerment. However, our understanding of the nature of any causal link between women's economic power and their access to reproductive rights and the magnitude of the connection in different times and places is very much limited. So in this webinar discussion, we aim to explore how poverty and reproductive justice or access to SRH services are interrelated. What do we know up to now and what more we could learn from the connections itself. So we are very grateful to have Amanda, Amina, and Shangari here with us today. So thank you, Amanda, Amina, and Shangari for joining us. So we would like to start with a self-introduction. So we can start with Amanda, then Amina, and then Shangari.
Thanks, Jelling. Hi, everyone. Thank you so much for joining us this evening. Very briefly, I'm Amanda. Previously, I was the coordinator with the Reproductive Rights Advocacy Alliance Malaysia, or RRAAM, where I also managed the hotline and ran research with my colleague, Amina. Currently, I'm pursuing my MSc in Reproductive Health Research at the London School of Hygiene and Tropical Medicine. Thanks.
Amina, please.
Thank you, Jalin. Good evening to everyone present here. Thank you for joining us. Please allow me to share some information about myself. I have been working with RRAAM since late 2019 as an advocate and researcher. Was given the opportunity to carry out and write up several pieces of research on sexual and reproductive health in Malaysia last year. I strongly believe in human and women's rights and definitely support pregnant persons having the right to make their own choices. I believe that the conversation being had around women's rights in this country are not necessarily focused on the actual lived experiences of women, and therefore there needs to be some serious change to the way these conversations are being had. I also staunchly believe in being kind, having an open mind, and constant unlearning and relearning. Finally, I believe that we should all absolutely work together to smash stigma and the patriarchy.
And Shangari, yes.
That was brilliant, Amina. Hi, everyone. I'm Shangri. I'm an economist. This is not my bread and butter. So I work for Bank Negara Malaysia as an analyst in the currency department. But I have a master's degree in development economics, where women's poverty, SES, and agency are very important research topics for me. I volunteered with Bank Negara with providing financial education programs to female-headed households. And I'm really happy and honored to be here with RRAAM for this webinar on one of my pet research areas. And I echo Amina's thing, let's smash the patriarchy. Back to you, Jali.
Thank you, Shangari. So from your introduction, you are an economist. So maybe you could tell us about the research from an economist's viewpoint, like why does sexual and reproductive health matter?
Okay, yeah. So a lot of the time when we talk about SRH, we talk about the legality of it, and we're talking about medical healthcare. But as you mentioned earlier, like linking women's empowerment to their reproductive rights. When we're talking about barriers to contraception and abortion, two things we need to talk about. The first being denial of access or difficulty in obtaining access. So this incurs short-term costs to women, like geographical cost of medical procedure. And the second thing is an outright denial of abortion or contraception, which incurs long-term costs. So in the first case, you are obtaining the abortion or contraceptive method, just that you're incurring costs in order to do so. In the second case, you're being denied an abortion, and the attendant costs for this are far more long-term. There's lost wages, lost retirement savings, labor mobility is gone, lost skills and skills building. During a woman's natural fertile age, that's the time where she has the most labor mobility and ability to build skills. Now, when a woman at this age, when a woman spends time outside of the workforce during this time, she can end up losing about 3 to 4 of her annual wages for each year out of the workforce. So it's a significant portion that we're talking about. And again, ultimately, we need to look at our female labor force participation in this country. Ours is really low. It's 51% of women in Malaysia are involved in our economy. And the male labor force participation rate is 80%. And nothing drives the gap in labor participation rate more than having children. So nothing that exposes and widens the gender wage gap more than having children. And then added to that, women bear the brunt of unpaid household labor, which doesn't count in our GDP accounting. Yeah. Before we go deeper into the weeds, let me put a caveat to all this. What has to be understood is that women need agency. It's one thing if a woman chooses to have a baby, if it's a choice to leave the labor force or to not enter it at all and undergo all these long-term costs that I just listed out just now. All these costs are baked in. There's an implicit agreement that there will be this cost, there will be the sacrifice. Now, this is already awful. It's a failure of our society that women have to bear these penalties just for having children. But if in the case where an abortion is denied to a woman, if one is denied the agency to choose or to not choose to have a child, and an unwanted pregnancy happens, that's not reproductive justice. So it boils down to agency. With no agencies, these penalties are forced on women.
So just now, we were talking about the agency of women and also the women's economics, the participation in in our labor force as well. So, but then the question here is that many members of the society, especially we have men and women asking the questions, like they object to the gender perspective, saying that it only looks after the interests of women. So why should we put attention to economic equality in women? Like, how does it benefit the country as the whole?
That's a good question, Darling. Okay, Malaysia, we're an upper middle income country. We're almost NIC status, newly industrialized economy status. And even with that, we have such huge untapped resources in the form of women's labor. So in the long term, if you want to avoid middle income traps and economic stagnation, empowering women economically means better returns for all of us. Like putting aside all the non-material benefits for more women to be fully engaged in the economy, like representation, etc. If all economic barriers are removed for women in Malaysia, household care, childcare burdens, the country's income per capita, I have statistics. Okay, the country's income per capita can grow by 26.2%. And that is an average annual income gain of 9,400 ringgit annually to everyone. So I think it's quite clear, if we take care of women, we take care of society.
Thank you, Shangari. So just now Shangari shared about like in nationwide, the economics of nationwide. So maybe Amina, you could share with us like how does it affect like in family?
Thank you, Jaling. Let us begin to look at women's roles in society. A study by the International Labour Organization found that women do 4 times more unpaid care work than men in Asia and the Pacific. A study by the New York Times in 2020 found that if women had earned minimum wage for the unpaid work they do around the house, that would have amounted to $10.9 trillion globally in 2019. Estimates from UNICEF suggest that all of those married before age 18, 18% are boys, while about 82% are girls. Women are more likely to work as unpaid family laborers or in the informal sector. Women farmers cultivate smaller plots and less profitable crops. Women are also much more likely to suffer domestic violence in developing and rich countries. Fewer women participate in formal politics, especially at higher levels. Around the world, women perform 2/3 of the work or 10% of the income and only 1% of the assets. In many countries, women are still not as deeply involved in politics as men. It has been shown in countries such as Egypt, the Netherlands, and France that female representatives not only advance women's rights, but also advance the rights of children and family-friendly legislation. On October 24, 1975, 90% of the women in Iceland went on strike as they were fed up with being paid less for the same work and doing unpaid labor as housewives. They called it the Women's Day Off. 5 years later, Iceland became the first country in the world to democratically elect a woman as head of state, a single divorced mother. She later said that the events of that day paralyzed the country and opened the eyes of many men, which set the nation's course towards achieving top-tier status in gender equality. In 2019, coincidentally, Iceland passed a bill legalizing on-request abortions within the first 22 weeks of pregnancy, regardless of circumstance. Women make up 50% of the global population, and women need to be represented and have their contributions valued. Looking after women and empowering women to exercise their rights and choices means looking after the welfare of families and children, which applies to almost every single one of us. Gender equality and women's empowerment are both human rights and are necessary for achieving comprehensive, unbiased, and sustainable development.
Thank you, Amina. So let's move our focus back to lived realities of the women's and also, everyday experience of the women's. So Amanda, you have served on the RRAAM hotline both as its manager and also the paracounsellor since 2019. So how consistent are your hotline experiences with what Shangari and also Amina have shared with us so far? Are there any like similarities or differences?
Thanks, Jaling, and also thanks, Shangari and Amina. I'm learning a lot from you two just from listening in. Yeah, I mean, economic realities have a very direct consequence on access to abortion and other SRHR services. And so it's an unfortunate reality that abortion access also includes financial access. without money, and also without the requisite empowerment that women need to be able to, own their access to resources such as money. Many who approach the hotline would simply be unable to afford the procedure costs quoted to them by doctors. And this is even though many on our referral list do often subsidize procedures and take into account the economic situations of clients who approach them. And so we saw these sort of restrictions, for example, during the first MCO last year in March, and I'm sure we'll talk about this more, but many people in Malaysia saw their livelihoods directly impacted with job loss and restrictions. It was unprecedented. The costs of the pandemic, I'm sure, is something that we'll be calculating for a long time to come. And we definitely saw how dire the consequences could be with our hotline clients who were coming to us and were simply now even more so restricted beyond just sort of societal restrictions, stigma, the barriers that already exist to access SRHR services. There was now an additional pressure and limitation economically. And this is so taking into, when we think about how even wanted pregnancies we were able to see were unable to go forward because families and individuals were reckoning with how they were simply unable to support another mouth to feed. Even despite their own personal feelings or what they wanted, we can see how far-reaching the consequences of economic limitation can be and what that lack of empowerment can look like for individuals and families.
Thank you, Amanda. So Amina, you spearheaded the two important pieces of research in 2020 with RRAAM. One which is interviewing the hotline paracounselors, which Amanda works with and works in as well. So I remember you guys interviewed on like why women seek abortions, and there's also another research investigating the types of SRH services provided by private clinics in Peninsular Malaysia. So tell us if have any of the paracounselors or doctors that you interview share any stories related to economic impact and the access of sexual and reproductive health care.
Thank you, Jaling. Let me first take you all through the hotline research. The biggest age group of women who contacted the hotline were between 19 and 24 years old. In terms of marital status, it was about equal for both married and single women. Out of all the clients, 52% already had children, and almost 90% of those who had children were married. I will be happy to share with you some case studies. A 17-year-old girl contacted the hotline at 5 months pregnant. She had only realized she was pregnant at the end of her first trimester. She could not afford to raise the 4,000 ringgit needed for the procedure. In the end, she told her father, and he told her to get married. She later contacted the hotline again for help with the unwanted pregnancy, as marriage would not have solved the problem. At that point, she was 25 weeks pregnant, and a termination was no longer an option. Another example is of a woman who was nearing 20 weeks of pregnancy and needed to raise funds for an out-of-state procedure. Although RRAAM offered to cover half the procedure costs, she was unable to raise the other half. And due to stigma, she would not have been able to get any assistance from her friends or family. We eventually lost contact with her. During the MCO, increasing numbers of women highlighted job loss or unsteady employment, either for themselves or their partners, as having taken a toll on their financial health, and as such was forced to seek safe abortions, even if it had been a planned pregnancy. As for the clinic research, I would like to highlight a significant research gap. The research shines some light onto the experiences of women who have had access to clinics, but we also have to take into account that the majority of women continue to have no access to information, let alone to be able to consult a doctor providing safe abortions. Even as Amanda and I were carrying out the research as representatives of RRAAM, we still faced so many barriers when inquiring about the availability of services, so even some stigma and judgment. I can only imagine the stigma towards pregnant women seeking termination of pregnancy. Safe abortions are still a profitable service, and unfortunately, many doctors tend to impose their personal values when it comes to the provision of the service. However, we must also look at the effects of abortion denial for women and for families. The reasons why women seek abortions are complex, yet financial or material concerns and timing are among the most important considerations for a family with, let's say, more than one child, or those who are financially unable to support the child. As much as people want to advise women to continue the pregnancy based on their personal opinions or moral and ethical beliefs, it is women and their families who have to bear the cost and toll of that pregnancy and childcare. So unless we are willing to support that child in any means necessary, I believe it is not our place to make decisions for women.
Thank you so much. Thanks, Amina. So about the research that Amina and Amanda work on, for our viewers, you can also access to both research. They are all published in RRAAM's website. We will be posting the link to the research later in the chat box as well. So it is back to the conversation itself. So it is very important to acknowledge that the number and the data of women who went like uncaptured during our research because they don't have access to the services at all. So, and Amanda also mentioned just now like how pandemic has worsened the financial difficulties experienced by not just women themselves, but also the whole family. So maybe Amanda can anyone would share like how COVID-19, it's been 2 years, how it makes like financial plight experience by women worse. Maybe we could start with Amina first.
So I can disclose to you that in relation to economic impact, none of the doctors we spoke to highlighted that the cost of procedure was an issue. But again, we do have to acknowledge that these people already had access to clinics and are mostly able to raise the funding needed. The cost of abortion services in the first trimester range from 600 ringgit to 1300 ringgit, and the cost in the second trimester range between 1200 and 5000 ringgit. The number of clinics providing second trimester services are significantly less and are usually centered in bigger cities such as KL, making physical access an increasing barrier, especially in recent times due to the pandemic environment. Some doctors disclosed to us that if they observed a need in women, they would be willing to reduce the cost of their services as they recognize that safe abortion is an essential healthcare service and is a right that women should have, and also because it saves women's lives. One doctor that we spoke to informed us that he would charge a woman whom he deemed to be well off a higher price for the procedure, but would also charge a woman a much lower rate for someone who exhibits financial need. None of the doctors we spoke to disclosed that the contraceptive uptake rate was low due to affordability, but rather due to lack of interest and partner disapproval. I would say that COVID-19 has worsened the financial plight of so many individuals and families, and this would mean that families would have less expendable income in general. This means that families would have to reconsider the number of children they can afford to have, or have to choose to terminate a pregnancy, planned or unplanned, if it means that they will be able to better preserve their physical, mental, and financial health.
Amanda?
Yeah, thanks, Amina and Jelly. Thanks, Amina, for your points. Thinking back to that time, which was, quite an intense period of time for us doing the research, especially in the midst of MCO. Two main points come to mind. One is that there is no ideal or perfect or even model client that the hotline receives. So there is no one type of individual there's not, there's a certain stereotype that people who need an abortion or who approach the hotline needing one, especially in dire circumstances, would have had to go through a series of events to find themselves in that situation. But the reality is that it's a wide spectrum, and and I think with the situation of the MCO and the pandemic, it kind of widened that spectrum even further of people who then suddenly found themselves in need of access to these services. And so from our hotline research, we found actually that 50% of our clients are actually married, and almost 50% of clients who approach us have one or more children at the time of calling. So we thought that was interesting to note as well, because it shows that when people are thinking about access to abortion, they're not just thinking about themselves, they're not, being selfish or whatever the term is, they're thinking about the children that already exist, the families that they already have that they need to support and to uphold, and this means financially as well. So my second point as well, in line with what Amina noted, is that medical abortion, which is performed through the ingestion of specific pills, namely misoprostol and sometimes mifepristone, is not made available in Malaysia through clinics. And medical abortion, in comparison to surgical abortion, which must be provided in a clinical setting, has been quite revolutionary around the world, and has actually been pushed through by many governments across the world that had not approved it for home use before, such as the UK, during the pandemic specifically, recognizing that medical abortion allows for women to receive the access in a safe manner that they need. So what happens with the fact that medical abortion is not permitted or provided openly in clinics in Malaysia is that the black market for it then opens up. So one direct consequence of that we saw in the hotline was that women were then being scammed by sellers of fake medical abortion pills. And so on one hand, you don't know what they're ingesting, potentially causing harm to themselves. And they also don't know that their pregnancies are then continuing. They think that because they've had these fake black market medical abortion pills that the pregnancy has been terminated, when actually it's not. And when a pregnancy increases in size, the costs of the surgical abortion that they have to go through then also increase with each week. So the strain or the future strain of the financial burden that they experience when they find out is devastating. So there were women who were coming to us because they had depleted all their funds on medical abortion pills that had not worked because they bought them from sellers. And then on top of that, their pregnancies were either past the first trimester limit. So if they were in a state that with clinics that did not offer procedures beyond the first trimester, they would then have to bear the financial costs and burdens of traveling to a different state. During an MCO, that was very difficult. And then also just the increased costs and the medical risks even of an advanced termination. So you can see how it's kind of like it's just one after the other. It was devastating in that sense that when you limit access to something that has been proven, that has been touted as safe, with proper guidance, with proper recommendations, when that is restricted, you see how the tiles fall down one after the other. And who suffers most? It's definitely the individuals and the families that then don't have the access. Yeah.
Amanda, just now you mentioned about the girls and women who they are late in their semesters, and also because they have already been putting being scammed with like fake pills, and they have no idea what they have inserted in their body or what have they taken. So, and if they are in an area that they don't have they don't have clinics who provide late abortion services. So what happened to them? Does RRAAM research capture about it? Do we have any ideas of what kind of realities they are living in, and what happened to them next?
Yeah, unfortunately, and these were, personally for me, very upsetting to see how devastating it was when some just don't have the option to go through an abortion procedure. They would then have to carry it out to full term. And then that would be when we would extend our help in terms of whether they would have options for adoption. But that just means that's just a situation that really could have been prevented easily, but because of barriers that have been set up in place, was forced to continue.
I mean, other than abortion, there's also, they could go for baby dumping as well. And I think maybe Shangari can share with us like some of the data that you have found about how the pandemic has like risen the experience of women during the pandemic.
Yeah, Jaling, and I'll get to baby dumping in a while. But yes, globally, as I mentioned, women in general have been more affected by unemployment during the pandemic. What has happened is the brunt of childcare and household domestic work has also fallen to women as well. So you also see a fallout of women from the labor force because of that. And also the lack of resources for SRH, access to women's clinics has been reduced, and also clinical staff has been reduced because all resources have been diverted to COVID instead. And because of the access, baby dumping cases have increased during the pandemic, and one of our hotlines have reported a 20% increase in calls on unwanted pregnancies in Malaysia. And it's the same situation globally as well. About 12 million women in 115 countries have lost access to family planning services, which is resulting in 1.4 million unintended pregnancies. So family planning services include like long-term and short-term contraceptives, like IUDs and such as well. So yeah, the situation, far from ideal, it's just sort of exacerbated the worst conditions that we already have ourselves.
Thank you, Shangari, and also Amanda on the very sad realities and also data that we just shared. So it's like everything is about money, just like our topic today. No money, no honey. If you want to go for contraceptives, you need money. If you want to go for abortion services, you need money as well. Even if you can't access to abortion, if you go for childcare, it's also money. So given the gap that is like growing between the rich and also poor, how does access to contraception and also safe abortion improve income inequality and to also like close the poverty gap? Anyone would like to jump in?
So talking about the gap between the rich and poor, let us acknowledge that accessibility to safe abortions in this day and age drastically increase when cost is removed as a barrier of access. Following this, distance can also be removed as a barrier by increasing access to private hospitals locally or overseas where you can obtain a safe abortion. It also means that women don't have the burden of having to figure out how they can arrange for childcare or having to take time off from work if they need to travel out of state for their procedure. When cost is not an issue, there is no need to raise funds through community, family, or friends, and a discrete procedure can be obtained through a private healthcare provider. But let us also remember that women of means who obtain abortions face stigma and judgment, especially because they are financially able to raise the child. Some factors that we can take into account are that if you have a large number of children, chances are you have to stop working to take care of them, which means you lose your financial independence and social mobility to a certain extent. In the unfortunate circumstance where the woman is vulnerable to domestic violence, having a child and having to stay at home means that they are now limited in terms of the opportunities to reduce the amount and type of violence inflicted. Increasing access to safe abortions and contraception means improving the lives of women and families. I personally got to know about a family in a PPR flat community where the couple have 9 children and live in a 2-bedroom flat. Only the father is employed and he earns minimum wage. There is a clinic near where they live, that could have provided family planning services to the mother, but the opportunity was not presented. Safe abortion and contraceptive access also mean that older siblings are not forced to drop out of school to stay at home and take care of their younger siblings, or undergo child marriage in order to support their families, or even become child laborers. It also means that parents and families do not have to bear the physical, mental, emotional, and financial stress of unwanted pregnancy. It has a drastic impact on the quality of life for men, women, families, and children in so many ways. And it also provides a solution to baby dumping and the harm caused to women in having to carry on with an unwanted pregnancy.
Shankar, you were about to say something just now.
Yeah, sorry. Yeah, just to follow on from Amina's point, like yes, statistically, the poorest people in this country are women, are single mothers, are female-headed households. Women and girls are more vulnerable to poverty and what we would call a chronic low socioeconomic status or poverty cycle. And unwanted pregnancies can trigger a poverty cycle as the head of the household has to drop out of the labor force. What both Amanda and Amina mentioned just now, that many pregnant people who seek abortions already have more than one child. And it's a let's move away from the conception that people who want abortions are young people or irresponsible people. It can be anyone. It's just when you already have as many children as that, one additional mouth to feed can make the difference between N40 and B40. Yeah, and another point being that wealthy people have always been able to procure SRH. In countries where abortion is banned, wealthy people have still managed to obtain abortions by paying for them. And this is another factor that exacerbates the poverty cycle and increases inequality.
Amanda, do you have anything to add on that?
Not quite, because that's been covered extensively, but I do think that's significant, especially in our country, to note that access to abortion is there if you have the money. So empowering women and giving them the financial options to access that is very important. Yeah.
Thank you everyone. So we have been talking about income inequality and what are the other inequalities that you all have observed, like that may be tied to women's poverty?
Let me start off with so with regard to the gap in female labor force participation, as I mentioned just now, there's also a massive gender gap in positions of authority. Very few female CEOs we see because of the, it just ties back to the loss of the skills building and the building of seniority, as I mentioned, because women drop out of the workforce at that particular age. Yeah, so representation is a major issue. Yes, and of course, in addition to that, like among the percentage of working women, those women are still shouldering the brunt of domestic work. So like even as they lean in at work, they're still doing all the unpaid labor at home as well. Yeah. So I don't know, there needs to be some kind of union for women. We need to unionize. We pay so much penalty for having children and we're not compensated for it. There's definitely a mismatch there.
Yeah. Other than representations and also the gender gap in positions and also in work field, Amina, I remember that you've been talking about how domestic violence. Maybe you could tell us like how domestic violence and also sexual abuse affects different economic and social class of women.
Okay, so far we have looked a little at how gender equality affects families and the economy. Communities are also affected by women's health and women's economic power. A study by UNICEF and UNFPA of low-income urban families found that female-headed households were disproportionately affected during the MCO. Children in these families had a less nutritious diet and faced increased disruptions to their education. Worldwide, calls to report abuse or violence in the home increased dramatically at the start of the pandemic. Higher rates of sexual abuse and violence were also observed within poorer communities. Poorer women and children are less likely to have the opportunity to lodge a police report or seek help when facing their abuser, let alone to escape the abuse. Early last year, I had the opportunity to speak with a lady running an organization called Project Red Dot that works to provide menstrual aid to low-income families. I was told about this father of 4 daughters who was struggling to purchase menstrual hygiene products on a monthly basis and had hence had to rely on the organization to provide it for them. Globally and in Malaysia, girls who do not have access to products are then forced to stay out of school for several days each month, disrupting their education. Women who are not made aware of their contraceptive choices and rights are forced to birth and care for any number of children, even if it is not their desire to. Young women who become pregnant are forced to marry and then denied further education opportunities or employment opportunities.
These are very important points, but also many are concerned that if we provide contraception to unmarried couples, or like we provide easier access to abortions, does it encourage like promiscuity? And what do you guys have to say about this? We can start with Shangari.
I would say, well, unmarried people are still going to have sex, like it or not. Like at this point, sexual maturation is occurring earlier and earlier, and people are getting married later. Abstinence-only sex ed has been proven to not work. It's better to prepare our young folks, and I think ultimately even more conservative people need to get used to the idea that contraception and abortion are better options than baby dumping. If
Amina?
I think that people who believe that are seriously under the wrong impression. And I think that it is extremely unfortunate that there are people with political power and influence who think the same way, because their empty rhetoric has very real consequences on real human lives. Let us not stereotype women and put them in boxes. Let us approach this with greater awareness about women's health, choice, and rights, and their real life lived experiences, much like yours and mine. If you would allow me, I would like to share. I vividly remember being in my school uniform as a young teenager. I think I was 13 or 14 at this time. I was headed into a debate on the pro-life versus pro-choice debate for my debate team in school. And I remember thinking how terrifying it would have been to face an unwanted pregnancy at that age. And just feeling so grateful that I would have an option to not carry on with that pregnancy. Obviously, at that time, I did not know that safe abortion is a privilege that not every woman and girl has. I would like to share a case study. A 31-year-old woman with 2 children contacted the hotline at 10 weeks pregnant. She was diagnosed recently with 2 mental health disorders, and her husband was a drug user who had left the household. Her second child was less than 1 year old. She was rejected when seeking a termination procedure at a government hospital. The cost of her private abortion procedure cost 1,000 ringgit. Despite the financial stresses caused by the costs of this procedure, she disclosed that she feels relieved after the abortion. I think, we often assume who these women are who are seeking abortions, and we feel that, we have a right to say something about that the fate of the unborn child, when in fact it really is a woman's reproductive health choice, a health choice that she should be able to make for herself, instead of having to be affected by the opinions of other people when it has to do with her bodily autonomy. Yeah, that's what I feel.
Yeah,
Breaking.
and to all those points, I also have to add that global estimates are that 1 in 3 individuals will fall pregnant or have an unexpected pregnancy in their lifetime, and out of those, 1 in 4 will have an abortion. So if these are the global estimates, imagine what that might look like in Malaysia without access or contraception or comprehensive sexuality education. And then that leads us to also think about how the rates for baby dumping in our country have not changed in almost 10 years. And I believe that in itself is a huge red flag. With our various ministries, they've been trying to tackle it. The reality is that the rates of baby dumping have not changed. And so I think that will force, that has to force us to take a hard look at ourselves and think about what is it that's not happening, that's not changing. Yeah.
Thank you, Amanda, and also Amina for sharing. So it's very heartbreaking to hear this. And so, what do you think is the way forward to improve the economic circumstances or situation of women, especially in the kinds of SRH policies that have been, not really working in Malaysia? As we can start with Amina.
We can start to recognize that women's economic participation and their ownership and control of productive assets speeds up development, helps overcome poverty, reduces inequalities, and improves children's nutrition, health, and school attendance. Women typically invest a higher portion of their earnings in their families and communities than men. Even looking at the Millennium Development Goals, none will be achieved unless there is greater equality between women and men and increased empowerment of women and girls. We definitely need initiatives to inform women, to empower them to make choices and provide them with options. Comprehensive sexuality education needs to be implemented for everyone without prejudice. Termination of pregnancies can be made less difficult to access through greater private-public cooperation. This is an issue of gender discrimination in the healthcare sector, not a discussion about individual sex lives. While we are at it, we can also recognize that providing women access to safe and affordable healthcare will drastically reduce their need to choose between carrying on with an unwanted pregnancy or resorting to an unsafe abortion or baby dumping. According to the World Economic Forum Global Gender Report 2020, gender parity will not be attained for almost 100 years. That means all of us are not going to be able to see a world where gender parity has been achieved in our entire lifetime. And that's a really scary thought. It's a scary thought for myself as a woman, for all the women that I know, and all the women that I don't know, as well as all the women who are going to be born into this world. What is the future like for them? What is the quality of their life? Even if we start to have a conversation, a good conversation, and start implementing change at this point, it's still going to take a really, really long time to undo all the harm that's been done. So I think the best that we can do to begin with is to listen and to try and understand the different perspective, because women are human beings. It's not a competition between men and women for supremacy. It's about advocating for equal rights, for people to treat each other as human beings. And yeah, and we definitely can begin just by listening.
Thank you so much, Amina. What about Shangari, like coming from an economics perspective?
Thanks, darling. That's so great, Amina. So what I think is that while we'll be talking about the economic access to all this, what we have to really go back to is the legal and the healthcare aspects of it. In terms of legality, like this is something that we have to do. Like access to abortion can't just be on the advice of the doctor. It has to be by choice of the pregnant person. We have to have like public funding for abortion and contraception, and also like vis-a-vis the private and public healthcare cooperation. There shouldn't be any barriers for unmarried women in public hospitals and clinics. Like there is no conceivable way that this is reproductive justice, that an unmarried woman cannot receive SRH treatment in a public clinic. Also reduce geographical barriers to clinics. Again, on the legal side of it, this very arbitrary abortion limit rule at 22 weeks is also very, it's arbitrary. Like, there's why the gestational period of 22 weeks. So yes, we need to consider a later term for that. And as Amanda put so eloquently, like legalized medical abortion, which is far less invasive and far more convenient for everyone. Finally, in terms of SRH, it can also mean access to fertility treatments so that women can postpone their fertile years. Yeah, from a non-SRH point of view, we can look at things like implementing parental leave instead of maternal leave, make it compulsory, as a few Nordic countries have done, for male partners to take parental leave as well, or they have to share that leave, just to reduce the discrimination on women, and make it less of a labor force participation gap and a gender wage gap between men and women. And of course, public funded childcare. I mean, as long as we're wishing for things, right? Yeah.
Thank you, Shangari. That's really good points. Yeah, I think a lot of our policymakers need to take note about it. So, Amanda, what about you? What do you think about this? Like, how to improve the economic circumstances of women?
Yeah, Shangari and Amina have made great points. And I think looking at how specifically COVID-19 has showed us or kind of forced us under a microscope to reckon with the limitations that are in place economically and with SRHR services, we need to continue thinking about that. Decriminalizing abortion, for one, I would say is huge on the list. With increasing access to services, or even allowing access, not even increasing access to services such as medical abortion, as Shangari mentioned. And so during the pandemic, we could see how some of the most progressive countries in the world consolidated their existing practices to ensure access to SRHR services, while others moved to lift unnecessary regulations. We didn't see that in Malaysia at all. I would say, if anything, it was made even more difficult. So there's a lot to work with and a lot to work on.
All right. Thank you so much. Thank you, Shangari, Amanda, and also Amina for the very interesting and also very harsh realities that we just listened to. So that's the end of our panel discussions, and it's now let's move on to the Q&A session. So for all our viewers, if you have any questions, feel free to put in the chat box, or maybe just leave it in the Q&A box. Yeah. So we have a questions coming from Akash to Amina. But Shangri and Amanda, feel free to jump in as well. So the question is there any legal resource for these young women forced to marry or deny education, or etc.? Or is this considered too personal and outside the jurisdiction of the law? Amina, would you like to answer it?
I think that's an interesting question. Thank you for the question. We have talked a little bit about privilege and women who are forced to marry or are denied education. Let's look a little bit at their lived realities. They come more often than not from low-income families. which means they have limited financial power and social mobility. For them to have access to things like healthcare or support from the police, there's definitely a lot of barriers. I think this is something that we highlighted in the research, that there are many barriers of access, and being an individual who is, let's say, experiencing something traumatic or something that's difficult, that's not easy to talk about, and then you have all of this stigma and judgment around you, chances are you're not even going to be able to admit to yourself everything that is going on, let alone to have someone that you can share to, let alone being able to share that with someone who is in a position to help you. I think, finding out about the demographics of women who contact the hotline, the women who have access to clinics, who seek information on services, or even talking about young girls who are forced to marry or who don't get to go to school. They are definitely not privileged people, and something that for us, when we think about it, it's something like going to 7-Eleven to purchase pads. We think, oh, it's right there. I can get it at Kmart. I can get it at 99 Speed Mart. I can get it at 7-Eleven. You can get it at any grocery store. But for someone who is not economically empowered, who they don't have the same choices as us. So for them to even think that they could go out and get help, it doesn't occur to them. They are already trapped by the situation that they're in. And I think that's the reality on the ground, the day to day. That's women's lives.
Yeah, I think it's very important to acknowledge the fact that we are in a very privileged position to assume that everybody are not trapped in any kind of situation and they can always be free to get help. I think it's very important to acknowledge that not everybody has the power of getting to go and reach out for help. What about Shangari and Amanda? Do you guys have any thoughts on that questions?
Yeah, if I could just take this. Akash's question is quite pointed. Is there any legal recourse? And I think we all have to remember that minors don't have a lot of legal agency in this country. So especially when there are laws that allow for child marriage in this country, especially for children who are as young as 12 and 13. This is I mean, it's not something that we can do. I mean, unless that the law comes about that you can't get married at this young age. But as it stands in some states in this country, that is the problem. Amanda?
Gosh. Yeah. Well, I actually don't know what to say. So I think marrying young, again, like you said, there isn't really legal recourse off the top of my mind, because Shangari, as you mentioned, minors already have such limited autonomy as is. Yeah, so sadly the answer is that I can't think of any.
Yeah, it is very sad that Malaysia still allows child marriage and things. It's a very complicated situation in Malaysia, and there it will be a long way to go for us to have a change in our laws or in our regulations and whatnot. So yeah, I hope that answered your questions, Akash. Yes. So any more questions coming from the basement?
Yeah, I think we have two questions coming in, and they don't seem any easier than the first.
Yeah. Okay, so I'm just gonna read out the first questions. Feel free to jump in anyway. So the realities faced by women who are unable to access contraception and safe abortion sound horrible. Yeah, it is. What inspired all of the panelists to keep working in this area, which most people would find quite traumatic and want to shy away from? Maybe we could start with Amanda, who has been a paracounselor since 2019.
What inspires the panelists to keep working in this area? Oh, it is traumatic, and I would have to say that the need is just so pressing that it's almost, when you're faced with it, you can't turn away. You know, when you're faced with someone who has such a pressing need, who, you know, is potentially, let's say, 19, still living with their parents can't find out that they need a termination, doesn't know what to do, has no financial means access. How do you like turn away from someone like that, you know? Or a mother with 4 children, her husband's disabled, she has no means of earning income as of now, the MCO is hitting, how, you know? And so the realities of pregnant persons and of families are very difficult. And so to me, I would say it's just difficult to turn away from that when you're faced with it.
Amina, so you've been a SRHR researcher, you've been working as a research officer in RRAAM for the past 1 year. So how's your experience in it and what inspired you to keep working in it, Amina?
I think the most like obvious thing for me would be that I'm a woman and I identify with other women who want to make reproductive choices, who are denied reproductive justice, who are forced into a life that they don't want to be living, because they are then responsible for several children that they have to give birth to and raise and put out into the world as upstanding citizens. It's their responsibility, and it's not necessarily something that I think is not something that should be imposed on someone. I've heard pregnancy and childbirth and having a child being described as getting a tattoo on your face. You can't escape it. That always stuck with me because it's so true. You can't escape it. And let me just get back to the question. Sorry.
So the question is what inspired you to keep working in this area?
That's straight so far away. What inspires me? I think, like Amanda said, it's definitely the need. We see the need of all these women and children, and then we see the consequences. And then we also, I think, because we experience it as women, it hits harder. If we are wishing today, I wish that there would be more men who were open to understanding why advancing women's health is important, and for them to advocate it, because men play a significant role in society, just as women do. I hope that by me working, it means that, some people's lives could have been changed, or some people learned how to help their friend, or instead of, judging and sharing their opinion with someone, they instead listened and understood that person's situation. Because as much as you and I and all of us here are sitting here and talking about this, ultimately it comes down to a woman's life, any woman's life. And I really think that, we can do more to support that situation, then we think we are definitely more capable. If only we are willing to, stop and try things differently.
Thank you, Amina. So the questions come to Shangari because your background is as an economist and you have this interest in SRHR. So what sparks your interest and like why or what inspired you to be, continue your research in SRHR and the economics of it?
Yeah. Thanks, Jaling. So what has brought me here is that when we look at the economics of it all, the inequality that we see, like the gender inequality, the wage gap, etc., can very easily be like you can place the blame squarely on reproductive rights and lack thereof, of course. Yeah. So putting aside all other forms of discrimination against women in the workforce, for in the same your wage gap if there was similar qualifications, etc., for both a woman and a man, and the wage gap, what reiterates that wage gap is the fact that a woman has to leave the workforce at least for the maternity period and stuff like that, and I think that that's something that can very easily be remedied if we know enough about it. So that's what has brought me into research about SRH and how we can't give up. We can't accept this as the reality of the situation and just that, women will be women and they will have to have children. No, that's not how the world should work. We shouldn't be penalized for having children. Many people do want to have children. Many women do want to have children. No one should be penalized for wanting to have children, but also no one should be penalized for not wanting to have children. So I think in a very roundabout way, that's it.
Yeah, actually what you say really resonates with me because as a 20-something girls and then women, I guess, it's very scary because you want to advance in your career, but at the same time you have people asking you why you not married yet, why you don't have kids, and then on the other hand you have people asking you, how much are you earning? And I've seen a lot of other women that when they drop out from their career and then when they would drop out from the workforce and then they just remain in the family, and after a few years, because they need to take out the time to take care of their children and whatnot, they just can't get back to the workforce even though they want, because they already lost the connection to it. Yeah, so it's really sad to hear that. And yeah, thank you so much for having people like Shangari, Amanda, and Amina to continue to work in this field and to advocate for women's rights and also for universal SRH services. So we have another question from Maya. Maya asks, are there any initiatives that have been done by RRAAM or other SRHR NGOs in order to encourage KKM to revise their policies regarding subsidized access to abortion and contraception in public healthcare facilities? She also asked, is it even possible to do so? So perhaps Amanda or Amina that have worked with RRAAM could share your experience with us, what are the initiatives that we have carried out previously?
So based on my experience working with RRAAM in the past 2 years, I'm no longer with them, but during that time, we were able to have dialogue with the Ministry of Health. As a stakeholder, they do acknowledge the work that we do, which is significant. And during that time, we're open to conversation with us about the lived realities, what we were finding out, as one of the only hotlines running this service for access to safe abortion on the ground. And so I believe that RRAAM still does advocate for the Ministry of Health to provide safe abortions. And in the words of Petra under the true spirit of the law, which is to provide for the physical and mental health of the pregnant person, an individual. So if KKM would do so, then abortions would be made much more affordable and accessible to pregnant persons, their spouses, their families, especially those experiencing financial difficulties. But we do also understand that within the public healthcare system, it is a reality also that it is difficult still, despite the law, to access abortions and sometimes even contraception for unmarried individuals seeking it. And so there is still a lot that needs to be changed. But I would say that in my experience, it was an open pathway for dialogue. However, the recourse of action taken is something else that can be said, so.
And also, I think I just add on to that question, like what other organizations that are doing similar work or like advocacy and education. One of our alliances is also FYIKL. They are a bunch of young youths that are very passionate in promoting comprehensive sexual education and also access to contraception and also safe abortion. So we will leave yes, Petra's already leave their Twitter handle in the chat box. So please follow them on Twitter, and also you can search them on IG and also Facebook as well. Yeah, so does anyone know like other organizations that are doing similar stuff as well that you would like to give them a shout out here? No? Not that we know. Yeah. Okay. So let's see if we have any more questions. Okay. Okay, we have another questions coming. SP Joe asked that we know that many doctors exploit their position of power to permit and provide abortion services, but there's little public debate on that issue. I think it's, yeah. Do you have any comments on that statement?
I believe that right now would be an apt time for me to share something that Amanda and I experienced when we were doing the research. We were at this one clinic where the doctor was carrying out a termination of pregnancy while we were there, and we were waiting outside. And he came out of the room, and he started talking to us away from the research questions that we had asked him, the interview questions that we had asked him earlier. And we were having a conversation, and we started talking about pain, subsidizing, not subsidizing, so sorry, reducing pain, using painkillers for the procedure. And this doctor proceeded to inform us that he actually gauges how much painkiller to give to a patient based on their race. And he came he kind of reached out to me, and he kind of like did like he was going to pinch me, and he said that Indian women tend to flinch before he even pinches them. So I find that at the end of the day, the doctors are still people who are providing a service, but that doesn't stop them, even as medical or healthcare professionals in the situation. It does not prevent them from imposing their personal values or their personal opinions onto that situation with the patient, which ethically, even if you ask me, I'm not an ethics expert, but it just doesn't sound right. But this is what happens, and these are experiences that women have.
Amanda, would you like to add on top of that, like the dynamic between the doctors and also the patients?
Yeah, I think that was. Oh, sorry. Did I think my.
You are unmute. Yeah.
Oh, sorry about that. I think that was an issue. I just wanted to add to what Amina was saying about our field research and the experiences that showed that doctors come with a lot of their own misconceptions and perceptions too, and this affects the quality of service that patients receive, such as the racialized stereotype about the pain thresholds of certain types of individuals. That in itself was very alarming for us to experience, and then to imagine beyond that what else might come with, in terms of race, ethnicity, religion, even age, socioeconomic status. All these things come into the very human service and delivery of medical healthcare.
Thank you, Amanda. Okay, Amina, yes, you would like to add something?
Yes, I also did want to bring up the issue of the doctor-patient dynamic. So I think what Amanda and I both observed while we were in the room conducting the interviews with the doctors is that we were there as researchers, so the doctors knew what kind of information to share with us. But I think just being there in that chair in the same position that women have to sit and have a conversation with the doctor. There's definitely power, like a power dynamic that the patient is facing an unwanted pregnancy and is seeking an abortion. A lot of people think that abortions are illegal. A lot of doctors treat abortion as well. It is an illegal procedure too. So we cannot take away the fact that if a doctor is sitting across from you and you are in a vulnerable position, and he says, "Oh, you should not have an abortion. You should carry on with the pregnancy. You should raise the child yourself, or you should give the baby up for adoption." Indirectly, that doctor is making that decision for that woman, because chances are she doesn't know who else to go to for help. Another doctor is, it's a lot harder to find than we think, and she'll have no choice because the issue is already so stigmatized. She can't just change her mind, or she can't speak to someone else. She doesn't have that support, so she ends up doing what the doctor tells her to do.
Thank you, Amina. It's a really great response on that. So we're coming to the last questions of today. So the last question would be the strong negative influence of traditional religion on women, SRHR, is very problematic. How would the younger generation deal with it? Anybody would like to answer to that? Perhaps Shandari?
Yeah, thanks, Charlie. I think that, again, it's important to acknowledge our privilege that we don't have, most of us don't have very strong religious ties that would dictate our every action. But I think that even within religion, there is a spectrum. And across that spectrum, there are a variety of religious interpretations, and a lot of them are based on compassion. And it's that and the practice of non-judgment that we should prioritize to create better conditions for women in Malaysia. A lot of our values are set in policy through a secular system, even though some of our policies are driven by religious underpinnings. But yes, so here in Malaysia, we do juggle these secular versus religious underpinnings, but let's not cast aspersions on just traditional religions on policy making.
Thank you, Shandari. So thank you for answering the question, and thank you everyone for participating in this discussion. It's very interesting and very vibrant discussions. So so here comes the end of our today's discussions. Maybe we would like to have like each panel to give like 1 or 2 sentences on like the key takeaways from this webinar. Maybe you can start with Amanda first.
Yeah, this was definitely very interesting. I had a lot of takeaways, but mostly how the lived realities of women are so intertwined with the economic realities and opportunities afforded to them as well. That really cannot be forgotten or neglected, unfortunately. And so access to SRHR equals freedom as well. And in the same way, economic freedom also means access to SRHR. They're just completely intertwined.
All right, thank you, Amanda. So Amina or Shangari, who would like to start first? Who would like to go first? Yes, Shangari.
Again, to reiterate, so I think to boil it down, the gist of today's discussion was basically on the 2 barriers of access. Number 1 would be the access to obtaining abortion services, or the no money, no honey of it all. And the second one is what the barriers to obtain an abortion can result in women's economic privilege, power being taken away from them, or as I like to call it, no honey, no money. Yeah, so it's a terrible cycle that we can easily do things about. So I'm glad that, RRAAM as an organization is fighting the good fight. And it's wonderful to be here and to participate with all of you, and to discuss these very, very important things that everyone should know about, and everyone should be participating in this same discussion and listening, as Amina said.
Right. Thank you so much, Shangari. We're also very grateful to have you here as well. Amina, yes.
I would like to thank the panelists and the moderator for the scintillating conversation this evening. I would like to leave you all with a feeling of goodness, or an empowered feeling, to kind of feel like you can shout it from the rooftops, to shout it into the echoes of the mountain, whatever, that women should have rights, and women's rights need to be respected, and we can definitely all do more to achieve that kind of feeling. But it's a sobering realization that we all walk away with from today's discussion, is that despite a conversation like this, that women's realities are not going to change overnight. In fact, they're not going to change for almost 100 years. And that's quite scary. And I hope that we use that fear and that feeling of like facing that something so scary, for us as women, as members of society, as human beings, to do something different, to try to be better. We can always learn, unlearn, and relearn, to improve not only our lives but the lives of the people around us.
Thank you, Amina. Like that's really powerful and very sobering as well. It's really powerful, and I think it's very right that we should all shout at women should have rights. It's very bombarding to hear that. We should always keep saying that. So that's the end of our discussion today. So I hope that the discussion today helps us, everyone here, to understand better the struggles and also the challenges faced by women to access sexual reproductive health services at different social and economic classes, and how comprehensive and universal sexual reproductive health services can help in closing the poverty gap and also to achieve economic equality between the genders and classes. So we need to acknowledge that we need to acknowledge our own relative locations, privileges, and also inequalities, and always resist the indifference when it comes to sexual and reproductive health and rights. So, and also need to be more critical when it comes to states' policies and also societal norms around SRHR as well. So thank you once again to Shangari, Amanda, and also Amina. Thank you so much. And also thank you for RRAAM for hosting us today. Yes, so that's the end of our discussion. If you have any comments or if you would like to give any feedback, you can always email RRAAM. I think Petra's going to leave the email in the chat box as well. So yes, there it goes. All right, so hold on. Let me just send this to all attendees. Right, so here's the Gmail of RRAAM. So feel free to give feedbacks or any comments. Thank you so much. Thanks, everyone. You can, yeah.